A Process Improvement Plan by Kimberly Gabriel, RN. This proposal outlines the implementation of an Ankle-Brachial Index, also known as ABI, testing program designed to improve early detection of peripheral artery disease, enhance patient outcomes, and generate sustainable financial return through efficient clinical workflows, targeted staff training, and strategic billing practices. As a registered nurse at a hospital-based outpatient cardiovascular lab, my role encompasses a variety of responsibilities that are crucial to the management and delivery of quality patient care. The purpose of this gap analysis is to identify areas of improvement within our lab's operations and explore strategies to enhance patient outcomes, staff satisfaction, and overall efficiency. My lab provides the following outpatient testing and intervention: echocardiograms, nuclear cardiac stress testing, vascular ultrasounds, and minimally invasive vascular intervention. The problem that I have identified is that my lab has yet to achieve accreditation for vascular ultrasound. For this, I have performed a gap assessment. A gap assessment of what is needed for the vascular lab to become IAC accredited showed that we will need a medical director over vascular services in the lab. A job description and contracts will have to be drawn up for medical director, and money will have to be allocated for this position. Fortunately, we already know which physician it will likely be. We will need to update all existing policies and write any that need to be written. This is at no cost. We will start informing our ordering physicians that IAC requires an ankle-brachial index with arterial ultrasounds. We will wait for our medical director's guidance to make it an official standard for our lab. Once all of the items listed in our gap analysis have been covered, we will then start the lengthy process of submitting vascular ultrasound studies and any site-specific protocols to apply for accreditation. Vascular accreditation involves meeting specific standards set by accrediting bodies to ensure that healthcare providers deliver safe and effective vascular care. These standards typically cover various aspects, including the qualifications of healthcare professionals, the quality of patient care, the use of advanced technologies, and adherence to best practices. Investigating gaps in our current processes and adhering to guidelines for accreditation are critical steps in ensuring the best clinical practices for 2025. Embracing evidence-based practice in nursing is equally important as it leads to better patient care and improved outcomes. By addressing gaps, updating policies, and promoting evidence-based practice, healthcare providers can stay at the forefront of quality care and ensure that their patients receive the best possible treatment. The above algorithm from the American Heart Association recommends ordering an arterial duplex anytime an ABI is suggestive of PAD, but IAC recommends ordering both tests simultaneously whenever a detailed patient history and symptoms are highly suggestive of PAD. Peripheral artery disease is a common cardiovascular disease associated with increased risk of amputation, myocardial infarction, stroke, and death, as well as impaired quality of life, walking performance, and functional status. Peripheral artery disease is classified into 4 clinical subsets, each with different level of severity. Asymptomatic PAD, the patients may not notice any symptoms. Chronic symptomatic PAD, including claudication. characterized by pain or discomfort in the legs due to inadequate blood supply, usually occurring with physical activity and relieved by rest. Chronic limb-threatening ischemia, which is a severe advanced form of PAD where patients experience persistent pain at rest, non-healing ulcers or gangrene, specifically increasing the risk of limb loss. Acute limb ischemia, a sudden decrease in blood flow to the limb, often caused by arterial blockage, requiring urgent intervention to prevent permanent damage or amputation. This article explains the importance of high-quality arterial studies in the diagnosis of PAD. Patients with a history and physical examination compatible with PAD are first evaluated with duplex ultrasonography, which does not require contrast exposure and produces portable and reproducible images. Ultrasounds are low risk and low cost for patients and a great tool for clinicians to evaluate the patient's level of disease without risk. Duplex ultrasound results are typically combined with limb pressure measurements to accurately assess arterial hemodynamics and functional impairment. Recent advancements in peripheral artery disease imaging have focused on improving diagnostic accuracy, enhancing visualization of vascular structures, and integrating molecular markers for better disease assessment. Advanced vascular imaging, innovations in duplex ultrasound, intravascular ultrasound, CT angiography, MR angiography, and digital subtraction angiography are refining the ability to diagnose PAD and guide revascularization procedures. The model of change this project improvement project exemplifies is Cotter's 8-step change model. As part of the process of trying to apply for IAC accreditation, a sense of urgency is easy to develop as we will need to have sufficient number of cases to present for the application process. As stated previously, doing these two studies together is an IAC standard. Since creating a sense of urgency has been easy, the correct people have been more than willing to join the drive for change. Having the correct people on the team, including a registered vascular ultrasound technologist, a vascular surgeon, and the director of radiology, is imperative to making this standard at my facility. This team, along with me, the vascular nurse, will also help identify any possible barriers to our success. Theoretical framework for change, Cotter's 8-step change model. Cotter's 8-step change model is a widely used framework for implementing organizational change effectively. It was introduced in his book, Leading Change, and focuses on guiding organizations through transformation. The 8 steps are: create a sense of urgency, build a guiding coalition, develop a vision and strategy, communicate the vision, remove barriers to action, generate short-term wins, sustain acceleration, and anchor the change in culture. This proposal outlines the implementation of an Ankle-Brachial Index testing program within our clinical operations to improve peripheral artery disease screening, enhance patient care, and generate new revenue streams. With a modest initial investment and minimal recurring costs, the program is expected to yield a net revenue of approximately $138,000 to $183,000 annually. Program rationale: peripheral artery disease affects over 8.5 million people in the U.S. Early detection and monitoring are essential to prevent complications such as limb ischemia and cardiovascular events. ABI testing is a non-invasive, cost-effective, and guideline recommendation diagnostic tool for PAD. Integrating ABI testing into routine care offers improved patient outcomes through early detection, alignment with value-based care initiatives, significant revenue potential. Equipment and supply requirements. ABI systems, Doppler device plus BP cuffs. We need 3. They cost about $3,500. And then $10,500 for the machine. Annual supplies, gel, cuffs, and maintenance will cost about $2,000 for a total of $12,500 projected. Staffing and training needs. To train 5 techs for 4 hours each at $40 an hour will be a cost of $800. Protocol development and in-service training for 10 hours at $50 an hour will cost $500. Additional tech time for 1,500 ABIs a year will cost $10,000 for a projected subtotal of $11,300. Workflow and IT integration, EMR template modification should take about 10 hours at $80 an hour. Billing and coding and audit setup should take 5 hours at $100 an hour for a subtotal projected of $1,300. Financial forecasts. Our initial investment for equipment, training, and IT infrastructure is $25,100 projected. Annual ongoing expenses for staff hours and materials is approximately $12,000. Revenue estimates at 1,500 ABIs per year. Our total annual revenue will be $150,000 to $195,000 per year, with a net annual profit of estimated $138,000 to $183,000 per year. Conclusion and recommendation. Launching an ABI testing program is a strategic investment in both clinical quality and financial sustainability. With a quick break-even point and high return on investment, this initiative will enhance vascular screening capabilities, strengthen our preventative care portfolio, deliver meaningful net revenue. Recommendation is to approve the initial investment of $25,100 to proceed with implementation. In a process improvement initiative like implementing an Ankle-Brachial Index testing program, the key stakeholders include individuals and groups who influence or are impacted by the project's success, both clinically and operationally. Here's a breakdown of the key stakeholders. Clinical leadership, the CMO, and the medical directors. Approve clinical protocols and ensure alignment with quality and safety standards, vascular surgeons, cardiologists, and primary care physicians. They order and interpret ABI tests, provide clinical oversight. Vascular technologists and sonographers perform the ABI testing, require training and protocol standardization, directly involved in workflow and documentation. Nursing and clinical support staff assist with patient prep and education, may help facilitate scheduling or data capture. Vascular lab director oversees diagnostic services, equipment utilization, and compliance. operations and clinical managers, coordinate implementation logistics, staffing and workflow adjustments, monitor throughput and scheduling, finance and revenue cycle team, evaluate reimbursement strategy and ensure coding accuracy, conduct ROI analysis and payer policy review, IT and electronic health analysts, they modify the EMR templates, ensure ABI results are documented, coded, and integrated into patient records. Compliance and quality assurance, ensure procedures meet regulatory standards. Example, CMS and the Joint Commission. They monitor outcomes, documentation, and potential audits. Training and education of staff. Deliver in-services and maintain ongoing competency programs for clinical staff. And of course, our patients. End users of the service, their outcomes and satisfaction are central to the initiative's value. Our facility will adopt team steps, team strategies, and tools for enhanced performance and patient safety to evaluate the effectiveness of our team collaboration. Team steps is an evidence-based framework that facilitates improved communication, teamwork, and patient care outcomes across healthcare teams. This system can be applied here to ensure seamless communication between the stakeholders involved in the ABI and arterial duplex process. By using team steps, the staff can enhance their cooperation, streamline the scheduling, and ensure that all necessary steps are taken to perform both studies effectively. Training is essential for success. Implementation of this new process, all stakeholders, especially the registered vascular ultrasound technologists, need to be educated about the importance of performing both studies together. Regular training sessions and workshops should be organized to familiarize them with the updated protocols and to address any queries they might have. Additionally, continuous education about the latest advancements in PAD diagnosis and treatment should be provided to keep everyone informed and motivated. A Gantt chart is a visual project management tool that displays tasks or activities over time. It's essentially useful for planning, scheduling, and tracking the progress of a project. Below is my Gantt chart for ABI testing program implementation. You will see that starting on June 1st, we will start with equipment purchase and setup and EMR template customization. Through June 11th, protocol finalization will be underway, as well as staff training. As of June 16th, we will start pilot testing. And then throughout the end of June will be our full rollout. Evaluating our ABI testing program implementation plan should be structured, measurable, and aligned with our clinical, operational, and financial goals. Evaluating an implementation plan isn't just about asking, did we do it? It's about determining how well the program is working in real-world conditions and whether it is delivering the intended value. This includes clinical, operational, and financial performance. We need to utilize a structured evaluation. A structured evaluation means you are following a systematic approach to collecting and analyzing data about the project. Ensure that all major aspects of the program are reviewed, clinical, financial, and operational. All relevant stakeholders are involved. There's a timeline for when the evaluation happens, 30 and 90 days and annually. We will need to use measurable metrics. The evaluation should be data-driven, not just based on impressions. This means defining key performance indicators at the outset. You can see here the evaluation timeline that I have set forth for this project. Implementing this new process may encounter several barriers that need to be addressed to ensure its success. Resistance to change is a common obstacle, especially when stakeholders are accustomed to established routines. Physicians, schedulers, and technologists may initially struggle to adapt the new scheduling and diagnostic protocol, which may lead to delays and inefficiencies. Another significant barrier is the potential lack of resources, including time, staffing, and financial constraints. Ensuring that all stakeholders are adequately trained and that the necessary equipment is available may require substantial investment. The management team must allocate resources strategically and seek additional funding if necessary to support the transition. The implementation of structured ankle-brachial index testing program represents a strategic investment in both patient care and operational efficiency. By leveraging evidence-based protocols, staff training, and EMR integration, this initiative supports earlier detection of PAD, promotes high-value care delivery, and enhances reimbursement opportunities. With relatively low initial capital and ongoing operational costs, the project return on investment is both substantial and sustainable, with potential annual net revenue ranging up to $180,000. In addition, the program aligns with broader institutional goals of improving cardiovascular outcomes, reducing diagnostic delays, and optimizing resource utilization. Implementing this protocol will allow the cardiovascular lab to move forward with becoming IAC accredited for vascular ultrasound. By engaging key stakeholders, maintaining protocol fidelity, and evaluating outcomes through defined clinical, operational, and financial metrics, the ABI testing initiative is well positioned to deliver measurable benefits across the continuum of care. We recommend moving forward with implementation and establishing a structured evaluation plan to ensure long-term success and continuous quality improvement. Thank you.